Hi, my name is Connie Goklannis and you're watching the video on the Prism Reflex test. This is the first video in a series of videos where we will be discussing how to go about assessing binocular functions. So we'll talk about various aspects of binocular functions, whether it be fusion or stereopsis or control of a intermittent deviation and so forth. So we're going to be talking about various ways to look at aspects of binocular functions. And we started talking a little bit about this if you look at our discussion around Worth-4 lights and Baggallini Strider glasses. Previously, we've talked about how those tests can give us information about sensory fusion and can give us information about simultaneous perception. So to some extent, these tests are also not only telling us about sensory adaptations, whether a patient has suppression, but it's also telling us about their binocular functions. So the Worth-4 lights is able to tell us, do they have sensory fusion? Do they perhaps have ARC, which is an adaptation that gives us binocular functions. So whilst in this particular module we'll be talking about tests that measure fusion or that measure stereo acuity and so forth, don't forget that the tests you've learnt previously that look at retinal correspondence or at sensory adaptations are also giving us information about binocular function, specifically and primarily about simultaneous perception, sensory fusion, and the presence of ARC, which gives us BSV. Let's turn to the Prism Reflex test. This is a test that assesses motor fusion, and we primarily utilise it, as you see in the images here, in young children or infants. A child from about, or an infant from about 6 months of age should be able to give you a motor fusion response. And in performing this test, what we're establishing is that a patient has binocular functions. So whilst we're only assessing one element of binocular functions, we're only looking at motor fusion. We're not getting information about sensory fusion, we're not getting information about simultaneous perception, etc. Not even stereo acuity, any of those things. But what we're trying to establish here is, does the patient have fusion, and specifically motor fusion? And from that we'll infer that the patient is binocular. So generally speaking, we utilise this in children and in infants who we want to prove that the eyes are aligned and straight. So far your examination, say your cover test, shows that there's no strabismus, but the patient has presented with a query. The parents maybe noticed that the eye turns some of the time. So your test, your cover test, is showing you that the eyes look straight. You assess their ocular movements, they all look full and normal, but you need a test to prove that the eyes are straight, that the patient is likely to be binocular. And the test we use in this population is the Prism Reflex test. Okay, and what we do is we choose a 15 or a 20 diopter base out prism. Why do we use a 15 or a 20 diopter base out prism? Well, if you can imagine, if you put up a base out prism in front of the eye, there will be a movement, there will be a convergent movement that occurs. And what we need to do is choose a prism that the patient can overcome. They can actually make a fusion or a motor fusion response to. Now, if you go too large, if you use a 50 diopter prism, the patient is unlikely to be able to overcome the size of that prism. If you use a base in prism, you're asking the patient to make a divergence movement, which is much harder for a patient. Convergence is easier. We have a larger convergence range, as we'll see in some subsequent videos. So we choose 15 to 20 because it is a moderately sized prism and because the patient should be able to overcome 15 or 20 diopters. I generally use a 20 diopter prism. I rarely use a 15, but you could use either or. And essentially what you see is you take the prism as you see here and you put it in front of one eye, base out, and then you're observing what happens to the prism, to the eye under the prism, and you then observe what happens to the eye that does not have the prism in front of it. So generally I'll do it twice. I'll put the prism in front of the eye, look at the eye under the prism, then I'll go again, I'll put the prism on top and I'll look at this eye. And then you'll flip it to the other side, you'll put it in front of the left eye, look under the left eye when the prism goes on, repeat it a second time, put it on there and look at the other eye. Now you can use a single prism, as we see here. In this infant, we see the patient has a single prism put before their eyes, or you can use the bar, and in this instance you would choose the 20 diopter prism to put in front of the eye. Okay, now let's go through what is the expected response, and we're going to go through what is normal. What do we expect in a patient who does have binocular functions? So we can see in image A here that we've got a patient fovea to fovea. So we're expecting that this patient will have binocular functions. And a prism, a base out prism, has been put in front of the right eye. Now we know the image is going to shift towards the base, and now the image has fallen off fovea. Because this is a fixing eye, then the eye will need to rotate, and it will rotate inwards to bring this fovea over here, so that now we can achieve BSV. However, the issue is that as this eye moves in, as the right eye moves in, the left eye will make a conjugate movement out. And we see these arrows depicting this eye moving out. So in that first instance, what we see is that the right eye moves in and the left eye moves out. But as the right eye moves in to bring the image on fovea, this image falls off fovea. And if we take a look over here, what we see is that this eye has now shifted to bring image back on fovea, and now this image is off fovea. And this causes diplopia. Now this diplopia is what drives the next movement. What we now need to see is the left eye move inwards so that the image falls back on fovea. By doing this, the patient will become bifoveal again, and the patient will achieve binocular single vision. So to reiterate, what we see is that by putting a base out prism in front of the right eye will move in, and the left eye will move out and back in. And so that is what we're looking for as a normal response. We're looking for the eye under the prism to move in, and the eye that does not have the prism to move out and in. And if this infant here, we see that this eye moves in and this eye moves out and in as we're observing them, then what we have is confirmation of motor fusion and confirmation that the patient is or has binocular functions. Now, what should we expect of a patient who is not binocular, who doesn't have binocular functions? What is the abnormal response? Okay, let's take the scenario of a patient with a right esotropia with a suppression scotoma. So here what I've drawn for you is a right esotropia. Here is the contralateral image point on nasal retina. Here is the fovea, and the blue line there represents suppression scotoma between the CIP and the fovea. Okay, let's say we put the prism in front of the left eye. Okay, as before, image falls off fovea. This eye will move inwards and this eye will move outwards. Okay, so far the same. Eye under prism, the left eye will move in. The eye without the prism will move out. Now, the question is, will it come back in to achieve BSV or bifoveal fixation? And the answer is no, it will not return. Why won't it return? Well, if you can imagine, as this eye moves out, the image will move in towards the suppression scotoma. And what was the driving force for the eye to move back in to achieve BSV or bifoveal fixation? It was diplopia. This patient will not experience diplopia at this point because whilst the eye did shift out, the image has sat within the suppression scotoma, and therefore there is no need to come back in. So firstly, the abnormal response is if you put it in front of the fixing eye in a patient with strabismus, the eye under the prism will move in and the eye without the prism will move out, but it will not return. It will not converge back in. Okay, what happens if you put it in front of the strabismic eye? So let's say we now put it in front of the right eye. What we see here is that the image shifts out and falls into the suppression scotoma. Will you now see the eye move to take up fixation with the fovea as you do when you put it in front of the fixing eye? No, the image has fallen within a suppression scotoma. There's no need for the eye to make a movement to put the image on fovea because it's not the fixing eye. So, if this eye doesn't move, will this eye move? No. So when you put the prism in front of the deviating eye, the eye under the prism won't move, and the eye without the prism won't move. So you get no movement of either eye. Okay, so when you're doing the prism reflex test, it is worthwhile that you do put the prism in front of the right eye and repeat the test in front of the left eye. Even if you're getting a normal response, it is encouraged that you perform the prism reflex test in front of both eyes. Why? Even a patient with binocular functions could give you some clues as to whether there may be issues. Say, for example, you have a patient with a nisometropic amblyopia. So they have a nisometropia, they've developed amblyopia, they have reduced vision, but they seem straight on cover test. When you go to do the prism reflex test and you put it in front of, say, the eye with a better visual acuity, what you may notice is that the eye under the prism will move in and the eye that's amblyopic may move out, but it may make a sluggish or a slow response back into the convergent position or back to as it tries to achieve BSV. So here again you have a scenario where yes, you're getting a normal response, but something looks odd about that normal response. It's slow, it's sluggish. So what you want to do is ensure that you have a look at the response when you put it in front of the right eye and ensure that you look in front of the left eye. And look to see for those sluggish responses as well as for brisk, quick responses. And you'll see that when you assess each other in the prac rooms, that for those of you who have normal binocular functions, that it is a very quick reflex movement that you see. It shouldn't be slow, it shouldn't be sluggish. Finally, in terms of recording, you should indicate that you've done a PRT. Some individuals put in front of it that it's a 20 diopter. If you use 15, you would use 15 there. And generally, most will indicate something like overcomes. You could actually write BSV response. There isn't a standard classic way of recording this, but you can either write overcomes or BSV response. In the second scenario, it just indicates here a PRT and it then indicates that the patient has overcome the 20 diopter. Again, you could write BSV response to 20 prism diopter prism. But just bear in mind, you should indicate the prism used somewhere or the size of the prism that you used to assess them on the PRT. Okay, that brings us to the conclusion of this video. Thank you for watching.